Are we good? All right. So my name is Mary Marcus, and I'm here today to talk about breast health and breast disease. My background includes a PhD from the University of Colorado in biochemistry, biophysics, and genetics, and the subject of my thesis research was the effect of estrogen and progesterone on the growth of breast cancer cells. And then I went on to get my MD, do a surgery residency, and so I just retired after 28 years as a general surgeon, where about 30% of what I did was breast cancer care and treatment. I'm also one of the researchers for the Marin Women's Study, and I'll be talking a little more about that. And have spent time on the board of directors of Komen for the Cure. So here we go. I'm going to spend a lot of time on this slide. There's, I think, about 25 slides altogether. Some we won't spend as much time on, but this is going to be a large part of what all of you do, which is treating benign breast conditions. Many patients will come to see you worried and concerned and will not have breast cancer. Remember, the lifetime risk for getting breast cancer is about 14% for people living in Northern California. So most of the patients you see are not going to have cancer, but they'll have a benign breast condition. Breast bud is part of normal growth and development, and in the prepubertal years, there's going to be a small lump of tissue immediately under the nipple areolar complex, and about maybe once or twice a year, I would see a young patient brought in by their mother concerned that she felt a lump in the child. What's most helpful in those situations is to focus your attention on the mother. She's the one at risk for breast cancer, not the child. It's very important not to disrupt the breast bud, and that's another thing you can see over years in practice, is that infants and very young children who have lung or heart surgery can have that tissue disrupted, and then they have asymmetrical growth. So it's important to result ultimately in not disturbing that tissue. So breast bud is part of normal growth and development. Fibrocystic changes are a large category of what you will see among women. What happens with each menstrual cycle is there is a growth and development of tissue. The body is thinking could get pregnant. There's fluid and excess tissue growth. Then the patient begins their menstrual cycle. They have their period. The body goes, oh, not pregnant. And the fluid and tissue that was built up is resorbed. Over many cycles, over many years, that can lead to some fluid trapping. When the fluid gets trapped or is inefficiently or incompletely absorbed, the body's response is to develop thickened walls around the cysts. Then with subsequent cycles, the ingrowth of tissue and fluid is creating pressure because the walls have been thickened, leading to breast pain. Fibrocystic changes can happen to most patients at some point in their lifetime. Up to 50% of women have some issues with fibrocystic changes. They don't predispose to breast cancer. If any of you have heard of Dr. Susan Love or Dr. Susan Love's breast book, that was the early research she did that made her famous as a breast surgeon. There was thinking in the 60s and 70s that fibrocystic changes were a precursor. That is not the case. And they do happen to up to 50% of women. Fibrocystic changes and the related breast pain from that can be addressed usually with non-steroidals, anti-inflammatory drugs. One of the best approaches is to simply tell the patient to take it 3 times a day, every 8 hours for 5 days straight. You sort of turn off the feedback loop to the brain that this is a pain you're not interested in. It's helpful to the patient just to know that pain is not a symptom or a sign of a potential bigger problem. And in about 75% of women, the changes are highly caffeine sensitive. And many women, if they decrease dramatically or discontinue all sources of caffeine, and that would be coffee, tea, cola, and chocolate, will have slow but gradual improvement in their symptoms. Hanging out at Starbucks and consuming a lot of caffeine is sort of increasingly a way of life. Many people don't realize that green tea actually can have a lot of caffeine in it. So they'll tell you they're not drinking coffee, but they're consuming several cups a day of green tea. So you want to explore that with a patient if they're complaining a lot of breast pain. Nipple discharge, if it's bilateral, clear, or thin like skim milk, is all within the range of normal. When you worry is when it's bloody and unilateral. And the approach is to smear some on a slide and send it for cytology. But nipple discharge is again something that many patients will come in with a complaint of, and it's almost always benign, but it can be a worrisome sign, and you do want to make sure you follow up on that very thoroughly. Fibroadenomas are another benign breast condition. The typical history from the patient is that they've had a lump there forever, and when you explore what does forever mean, they mean years, possibly even a decade or two, and it's been slowly growing. It's the kind of thing that will increase in size by about 10% per year. So it's very slowly growing, and yes, at some point, 5 or 10 years later, it's way bigger than it originally was, but it's very, very slow growing. It's been there a long time. Tends to be rather rubbery, rather distinct. In a young woman, I don't always recommend, based on that history, that the mass be removed. But at some point, as a patient reaches their late 30s, early 40s, fibroadenomas can get quite large. And I've had patients come in with something, the size of a tennis ball. And that becomes concerning for later screening, both for breast self-exam, clinical exam, and mammography. You've got, a giant lesion in the way. So at some point, we usually do remove fibroadenomas. Occasionally, you'll refer the patient for a core needle biopsy to confirm that that's the case. But the key history is that the mass has been present for years and that there's only one. Finally, cysts. The typical history when a patient has a cyst, which is a part of the spectrum of fibrocystic changes, is that they have a sudden onset of a large, painful mass. Some patients come in with cysts that you can literally see from across the room. They go from, having a normal exam to, again, having something that contains, easily 10 cc's of fluid. Cysts are soft, they're roly-poly. You definitely get the sense that, there's a water balloon down there. Often it's going to happen on the PMS days, just before they start their period. And if you've got all those features going on, if you're using intra-office ultrasound, that's a way of assessing for a large cyst, but frequently on clinical exam with experience, you can become aware of what a cyst looks like, feels like, and the history is key. This thing was not there 48 hours ago, now it's there, it's large, it's usually painful because it's the sudden onset of a fairly large mass, and aspiration is the key to diagnosis. Years ago, we used to send the cyst fluid for cytology. Because after, looking at 10,000 of them, none of them were cancerous. That's no longer done. The fluid is usually of two types. Sometimes it's a clear straw-colored fluid. It looks basically like serum. And at other times, it's a dark, thin black fluid. We call it crankcase fluid. And it reflects the fact that there was old blood in it that slowly reabsorbed. Clear-cut bloody fluid is a whole different situation. That's a cause for immediate referral. But straw-colored fluid, crankcase fluid, not anything that you need to worry about. In the crankcase fluid, it's very obviously different than fresh blood. Thin, black fluid, sometimes with a greenish cast to it. And those patients need to be told, though, that their cysts can reoccur, and they can recur fairly quickly. Some patients will say they got a cyst aspirated once, didn't come back for, 2 years, 5 years, 10 years. Other patients, the cysts are back in a week. You don't chronically aspirate. You aspirate once, establish what the diagnosis is, but you don't keep seeing people back for week after week for repeated aspirations. So that's the bulk of the types of benign breast conditions that you would see. Dangerous clinical findings. When do you worry? When do you start considering referral and referral quickly? First is asymmetry. Symmetry on exam is one of the key ways you can sort out the differences between fibrocystic changes and a worrisome mass. Symmetry on exam, most patients with fibrocystic changes, you're going to see it in the upper outer quadrant of the breast or in what we call the inframammary crease, that ridge of tissue just below where the breast tissue is adjoining the upper abdomen. That's the most common place for, plate-like changes and thickening or long, thin, ropey changes. But asymmetry, something that's clearly present on one side and not the other, that's a dangerous clinical finding that warrants a referral. So using a symmetric exam is your friend. It's one of the ways you're going to figure out if the patient has something to worry about or not. And so whenever you see someone who is complaining and they're saying it's just on the right side, it's just over here, start with the left side. Get to know what's normal for them. Then you go over to the side where there's a question. If you can get a sense of symmetry, you know you're in a much better zone than otherwise. So always examine both sides regardless of the patient's complaint. And my personal preference is to examine the side that they don't feel has a problem first. Then go over to the side where there's a complaint or an issue to address. Again, unilateral bloody nipple discharge, that is something to worry about. That needs to be sent for a smear on a slide, air dried or alcohol dried, and then you need a referral for imaging and follow-up. Obviously, any complaint of a new mass, particularly if you do not get the sense of a cyst. If they say, yeah, I thought there was something there 3 or 4 months ago, now it definitely seems like there's something there. The average breast cancer doubles in size every 100 days, so about every 3 months. So you want to try to get a sense from the patient of new mass means it wasn't there a year ago, or new mass means you thought it might be there 3 or 4 months ago, now it's clearly there. That's the kind of history that's worrisome. Obviously anything growing, like I said, fibroadenomas grow slowly. Some of them achieve sort of a steady state. They hit a size of about not quite an inch and then stay that way for years and years. But something that's clearly growing, that vague sense of, I don't think there was anything there, then I thought maybe, now it's clearly there, that's the worrisome history. Nipple retraction, that's a area that can be fraught with exam difficulties. The first thing you want to know on a history of nipple retraction is it new in onset? Some people are born with slightly depressed nipple areolar complex, so you want to know how long has it been present, how rapidly has it progressed, if there's a history of it being progressive. On exam, you want to see if with manipulation you can relieve the retraction. But when you see it as a sign of a cancer, it's as if the area is tethered down from below and it can't be manipulated to normal position, and it's always unilateral. It's very rare to see a patient present with bilateral breast cancers. It happens, but it's very rare. So again, symmetry, asymmetry, and the history, something new, something different, something progressive. Skin changes, we get very anxious over a certain type of skin change when you're trying to rule out a breast cancer. Many patients get mastitis, which is a routine breast infection, but a mastitis that doesn't resolve with antibiotics can be what's called an inflammatory breast cancer. Inflammatory breast cancer, although rare, is very aggressive. The life expectancy in a patient diagnosed with inflammatory breast cancer can be as short as 6 months. And so you really need to be aware of any patient who is coming in with warm, red skin, sudden onset. And what helps, but not always works, what helps differentiate between mastitis, which is a routine breast infection, and an inflammatory breast cancer is the inflammatory breast cancer can be painless, and it's not going to be associated with a fever and general, overall feeling of being fluish or unwell the way a patient would with an infection. And the other thing you look for is what we call peau d'orange, which is French for skin of the orange, and the skin of the breast in the involved area literally looks like the skin of an orange. There's that vague sense of dimpling It's a little thickened, and then there's the warmth and redness. When I see a patient with a mastitis or a breast infection, no matter how sure I am that that's the diagnosis, I put them on antibiotics and I see them back in 48 to 72 hours. If they're not substantially improved, then we go on to next steps, including more imaging and biopsy. But you need to be absolutely sure you're not dealing with a patient with inflammatory breast cancer when you see those skin changes. The other skin change that's worrisome for a breast cancer would be an indication of what we call Paget's disease, P-A-G-E-T, Paget's disease. Paget's disease usually starts as what looks like eczema of the nipple area or nipple areolar complex. So you begin to see, some flaky skin. It looks irritated. Maybe it's a little moist, desquamated. And again, if that doesn't respond very quickly to dermatologic care, you want to refer that patient for further imaging and biopsy. Paget's disease as a breast cancer reflects the fact that there is a cancer immediately below in the nipple area, and the cells are desquamating through the ducts. So you want to not miss that. When I see patients with Paget's disease, they will occasionally come to me having used hydrocortisone creams and so on and so forth for 6 months. You don't want your patients in that situation. You see skin changes, get the appropriate referrals, follow up, make sure that the patient really is getting better. And if they're not getting better, then you need to go to the next step. %40 of malpractice cases in medicine in general involve a missed breast cancer diagnosis. That is a huge number. Almost half of all the cases going to trial for medical malpractice are a missed breast cancer diagnosis. And the way you prevent that in your practice is you have an algorithm for the common clinical findings to make sure that the patient gets the proper workup every time. I cannot tell you how many times someone from, an adjacent clinic down the hall in my office would come to me and say, "Can you just check this lady real quick? Her sister just got diagnosed. She's worried. Can you?" Got to do the right thing completely every time. And have in your mind, even if it's written on an index card that you carry in your pocket, when I see nipple discharge, these are the steps, A, B, C. When I see warmth, red erythema or skin changes, these are the steps, A, B, C. When it's a new mass, what am I going to do? And when it's a new mass in a 20-year-old, how do I address that versus a new mass in a 65-year-old? Because remember, breast cancer, your risks increase with age. And so you want to have a sense of a plan and an approach for every one of those common clinical problems. And you want to make sure that you follow that algorithm every time. Because 40% of malpractice cases involve a missed breast cancer diagnosis. So how do you adjust your algorithm according to the patient and who you're seeing in front of you? Well, one thing is you do an assessment of the risk factors, and the biggest risk factor is age, getting older. Breast cancer happens in women in their 20s and 30s, not very often. Breast cancer happens to women in their 30s, 40s, and 50s more frequently, but still the person at greatest risk is the 85-year-old. And common thought among women is that, once they get over 60 or 70, they think that they're not at risk. For some reason, it's people in their 40s and 50s who seem to feel that they're the greatest risk. They're the people coming in most often with worries and concerns. But the greatest risk for getting breast cancer is getting older. Genetics is increasingly playing a part in breast cancer and a breast cancer diagnosis. You probably are all familiar with the Angelina Jolie story. There's 2 genes currently that we test for, BRCA1, BRCA2, and that stands for breast cancer 1, breast cancer 2, BRCA. Patients who are carrying those genes have anywhere from a 50 to 80% risk of breast cancer. They're also at risk for ovarian and somewhat for uterine cancers. Genetics testing for those genes is not something that is routinely done. The cost of the test is $3,000 to $5,000. So anyone who is considering genetic testing needs to have a discussion with you first as the person who might order the test. In my practice, the testing wasn't done without a referral to a genetics clinic. And the genetics counselor did a detailed history, made a family tree, and then calculated what is this patient's real risk of testing positive. Because if the risk of testing positive is random or near zero, you're not going to order that $3,000 to $5,000 test. So, plus, if the result is positive, if the patient does have numerous first and second degree relatives with cancers concerning, you're beginning to think, yeah, this patient could be a gene carrier, the role of the genetics counselor is to talk to the patient before the test is done about the implications of a positive result. Do they want to act on the positive result? If they don't want to act on it, maybe there's no point in testing. And what does acting on the testing result mean? It can mean undergoing prophylactic bilateral mastectomies. It can mean having your ovaries removed or hysterectomy. Or it can mean a mammo yearly, starting even in your 20s, and an MRI of the breast done yearly, with those two tests being done every 6 months. So you get your mammogram in January, your MRI in June, your mammogram in January. So there's some sort of detailed imaging going on every 6 months. It usually leads to a lot of biopsies because every little lump and bump is going to be of concern because this patient is so high risk. Most patients at some point after undergoing aggressive screening will opt for prophylactic mastectomies, but some patients will choose to wait until they're married and have started a family. And I think that that was exactly what was going on with Angelina Jolie. I'm sure she knew her history for a long time. She had so many relatives who died of breast cancer. But most people at some point will opt for prophylactic surgery. But very important in the genetics counseling zone to make sure that your patient is seeing a genetics counselor before you even consider drawing that blood to get the blood test. Finally, less than 5% of breast cancers are in patients who are BRCA1 or BRCA2 positive. Most cases are random. And so when a patient says, oh, I don't know if I want to get mammograms, after all, it doesn't run in my family, that is, unlike some cancers, some colon cancers run in family and so forth, the vast majority of patients who get breast cancer have no family history or a family history of one distant relative. It's not, the vast majority of women getting breast cancer are not gene positive. It's not running in their families. And so screening applies to everyone, not just people with a family history. Other risk factors are hormonal, and I'm going to go into much more detail on that. The basic fundamental idea on the hormonal mediated risk factors is the more peaks of estrogen and progesterone, the more cyclical peaks that are part of the normal course of a menstrual cycle, the higher a patient's risk for breast cancer. And the fewer hormonal peaks and valleys over a woman's lifetime, the lower the risk for breast cancer. Finally, there's external risk factors, and again, I'll go in a little more detail on this, including diet, exercise, and exposures, primarily radiation and toxic exposures. So the hormonal risk factors, they're all things that ultimately contribute to decreasing the number of cycles. So the age at first period, age at menarche. The age at first birth, there's increasing evidence that there's these pluripotential, not fully divided cells within the immature breast. And as a young woman goes through the first pregnancy, including delivering a term child and nursing, those cells do their final differentiation. So in a patient who has their first child very late in life, in a patient who is never nursed, or in a patient who never has children, their risk for breast cancer are increased. There's something about those pluripotential cells sitting there that seems to increase risk, probably because at some point there's some error in DNA. But when that final maturation occurs earlier, it decreases the risk for breast cancer. Lactation history, many women when lactating have few or no periods. So the more time a woman has spent nursing, the less the risk for breast cancer. Age at menopause, again, having your first period late in life, 16, 18 years old, and having your last period earlier in your 40s, fewer menstrual cycles over the course of the woman's lifetime lowers your risk for breast cancer. Use of hormone replacement therapy. The big nursing study came out, I think, in 2004. After that, there was a precipitous drop in the use of hormone replacement in postmenopausal women. There's no question that it increases your risk for developing a breast cancer. The ballpark figure, there's so many studies you can look at, the ballpark figure that most OBGYNs use is that for every year of postmenopausal hormone replacement therapy, it increases your risk for breast cancer by about 1%. So if a woman is going through menopause and she has terrible insomnia and headaches and she's miserable and so on and so forth, it's not unreasonable to take hormone replacement for a short period of time. But what I see most often is that patients start having irregular and heavy periods and a lot of cramping in their early 40s, and they start taking birth control pills. And 10, 15 years later, they're just still taking them. And that's now heavy-duty hormone replacement. That's, because hormone replacement in general is a smaller dose than birth control pills to begin with. Some researchers feel that an estrogen only, not an estrogen plus progesterone hormone replacement, might be safe. That's not something that's been nailed down clinically as being correct. The reason you add estrogen and progesterone is that for a patient who has not had a hysterectomy, the risk of uterine cancer increases if you do estrogen only. But there's some thinking that estrogen only might not be associated with the increase in breast cancer. I think that's still experimental. There's a lot of people with a lot of theories, but there's no final answer on that. So at this point in general, use of hormone replacement postmenopausal is discouraged, still done, but discouraged and limited, because you don't want your patient suddenly realizing 10, 15, 20 years have passed, and now they've accumulated a very high risk for a breast cancer. External risk factors include diet, radiation exposure, environmental exposures, and then, again, hormones and fertility drugs. Diet, we know that fat tissue contains an enzyme called aromatase, and it increases your estrogen levels. So obesity in general is a risk factor for breast cancer. And obviously any diet changes that lead to obesity are going to increase your risk for breast cancer. It increases your estrogen levels. So diet definitely is part of it. And I think as the childhood obesity epidemic goes on, we're going to start to see more and more cancers and all sorts of problems in, this, like, what is it, 1/3 of young children are obese, and they're setting themselves up for more and more problems in decades to come. Radiation exposure is definitely a risk factor for breast cancer. We tend to not think it's, a dental x-ray or a chest x-ray here and there. But the kind of radiation exposures associated with breast cancer are radiation for childhood lymphomas, radiation. A lot of people, there was a trend with scoliosis of kids getting spinal x-rays like every 3 months to monitor their scoliosis and their progress. And so these kids are getting, spinal x-rays, which are going to be a little higher penetration than a chest x-ray. And it was every 3 to 6 months between the ages of, say, 6 and 16. That was probably a bad idea. Radiation exposure in stewardesses. Whenever you fly across country, when you're up higher out of the ozone layer, you get radiation exposure. The amount of radiation exposure in a cross-country flight, San Francisco to New York, is the equivalent of a chest x-ray. So there is a small but real increase in breast cancers and radiation-related cancers in pilots and stewardesses and in people working in the airline industry. Environmental exposures, I'm going to talk more about that a little later in the lecture this morning. But it's DDT, phthalates, PCBs right now that we know of. Hormones and fertility drugs, we've talked about postmenopausal hormone replacement. Birth control pills seem to be neutral. They are an artificial source of estrogen and progesterone. They're in a lot of different formulations, and it's very hard to know as the formulation of the pill has changed with each decade. But they also work by creating a pseudo-pregnancy. When a patient is taking birth control pills, their levels of estrogen and progesterone are just high enough that they don't ovulate, and that's why they don't get pregnant. So you're also eliminating the spikes that we associate with an increased risk for breast cancer. So in doing what we call meta-analysis, where you look at numerous published reports on the risks of birth control pills and breast cancer, and so they can put together a study of 1,000 patients in England and 1,000 patients in Japan and 1,000 patients in, the Midwest and 1,000, and you put all those together, you do a meta-analysis. Now you're looking at the effects of birth control pills and breast cancer development in, say, 10,000 women, and it seems to be neutral. Some studies show a minimal to slight increase in risk. Some show a protective effect. But in general, we tend to think that it has little or no long-term effects on breast cancer risk, as we know it now. But we never know with all the pill just changes formulation, and there's always going to be a lag of several decades before you really know what's going on there. Fertility drugs, however, are a whole different situation. I think women who take heavy-duty fertility drugs to conceive and carry a child in their 50s are definitely putting themselves at increased risk. The long-term effects of drugs that stimulate ovulation, fertility drugs taken by people in their 30s or 40s, that's less well studied, but I think there's no good quality long-term data on the effect of fertility drugs. Certainly, you remember John Edwards, who ran for president, and he had the wife Elizabeth Edwards, and she got breast cancer. She had 2 children in her 50s. And it was all fertility drugs that created that situation for her. And she died of metastatic breast cancer. I remember reading a story about them long before their situation exploded, and I was like looking at this thing going, okay, so then she had a child at 52, and then she had a child at 54, and I'm sitting there reading her story thinking, wow, this lady's at real increased risk for breast cancer. And 2 paragraphs later, it's like, and then she got breast cancer. So I think the fertility drugs are something where, in the years to come, we're going to learn a whole lot more about the long-term consequences of that situation. But at the end of the day, modification of risk factors is not the same as prevention. We know a lot of things that increase risk, but we don't know what causes breast cancer. There is no ironclad way to prevent breast cancer. And patients with no risk factors at all make up 40% of breast cancer cases. So 60% of the patients we see, you can look at their history, you can look at how they've been living their lives, their health status, and sort of say, all right, it was probably this, this, and this that increased their risk. But 40% of the patients we see don't have any of the known risk factors for breast cancer. So there's still a lot out there that we don't know. Modification of risk factors is still a good idea, but is not the same as completely preventing breast cancer. So one of the things that then becomes important is screening. Now, screening is looking at healthy women with no symptoms. All right, that's the definition of screening. Screening doesn't prevent breast cancer. Actually, the goal of screening is to find it when it's early and treatable. All right, so screening is looking at healthy women with no symptoms. The purpose is to pick up the disease early, which then increases treatment options. When the disease is picked up late, Your patient is probably going to need mastectomy. They're probably not going to be a candidate for reconstruction. They may need a full node dissection, which can be disabling to their long-term arm function. And they could end up needing a year of chemo or more. When the disease is picked up early, it's far more treatable with, more palatable treatment options, including lumpectomy. If they choose mastectomy, they can have reconstruction. They may or may not need chemo. They may or may not need radiation. They probably won't need the full node dissection. There are benefits to picking up the disease early. Now, screening has been a source of great confusion in the media lately. There's a lot of unusual recommendations regarding screening. Most or many organizations that are involved in caring for patients with breast cancer, Komen Foundation for the Cure, most breast cancer surgeons and so forth, still support a mammogram every 1 to 2 years in the 40s, yearly starting at age 50. And it's a source of great confusion, but the official recommendation is that you stop doing mammograms when your patient's life expectancy becomes less than a few years. So if you have a patient who's 78, but totally healthy, living independently, driving your car, going to the store, going out and about, traveling, they should get a yearly mammogram. The risk for breast cancer approaches 1 in 8 women as a patient approaches age 80. So your screening is going to be most helpful to your elderly patients. Risk rises as the patient ages. You stop screening when the patient has other problems such that you don't think they're going to live more than a few years. So I see patients all the time who said, well, I turned 65 and I thought I didn't need to anymore. That's not how it works, actually. Now, the debates about mammographic screening in the younger age group, most, if not all of the studies have looked at death from breast cancer as the endpoint. That's kind of a dramatic endpoint. Most surgeons and people who care for patients with breast cancer look at treatment options. No, the mammogram didn't change the patient's outcome. It detected the cancer earlier when it was more treatable. But to say that mammography in the patient's 40s or even in their 50s is going to save their life, that's giving the study, which is a screening study, too much credit. The other parts of screening, well, okay, let's get back to this. So ideal screening. What does screening involve? Well, it needs to be quick, it needs to be easy, it needs to be painless, and it needs to be as accurate as possible. If your screening test takes an hour, well, now you can only screen reasonably 8, 9, maybe even 10 or 12 patients a day. But a screening test that takes an hour isn't helpful, and most patients aren't going to do it because it takes too much time out of their day. So it needs to be quick. It needs to be easy and painless. If it involves starting an IV, God forbid it involves sedation, or that it's especially painful, again, you're not going to have patients come in for it, and so it's not a useful screening test if it's not easy and it's not painless, and it needs to be reasonably accurate. And again, that's part of the debate over mammograms. Mammograms are 90% accurate. That's good. It's the best that we have out there. But that means that 10% of the women who have breast cancers are going to tell you, well, I had a negative mammogram. Didn't help me. That's true. But it helps 90% of the people. So it needs to be as accurate as possible, but mammography is not perfect. The other thing that mammograms do that has led to some of the debate is that they detect a lot of changes that are sometimes called precancerous. The official word for it is that it's detecting in situ cancers. Invasive cancers are the kind that spread and invade other tissues. They have to have treatment or your patient's going to die. In situ cancers will become an invasive cancer about 40-50% of the time. The problem is right now we don't know which way a patient's going to go. So one of the debates about the value of mammography is that it detects a lot of in situ cancers. And we treat those patients. because we can't predict, if you have an in situ cancer, who's going to go on to develop an invasive cancer and who is going to remain in a steady state and peacefully coexist with those changes. So some of the research out there saying that mammography is not helpful is looking at the women with the in situ cancers and saying they've been overtreated. But if someone says to you, you have a change and a 50-50 chance it's going to kill you, do you want to do something about it? Most patients are going to want to do something about it. And yes, that means half of the patients had something done that they didn't need, and half of them, you saved their life. Until we know more about which way a patient's going to go, this is the best we have. So when a patient talks to you about screening, this is some of the background, these are some of the issues with the current debate over mammography. But when a patient says, well, I have no family history, so how about I start at age 50 and do every 3 or 4 years? Remember, most patients who have breast cancer do not have a family history. Only 5% of cases right now are genetic. So we can't predict well who's going to get it, and our tests aren't perfect. But for the moment, they're the best we have. Screening is a tripod. It's 3 things. It's not just one. It's not just get your yearly mammogram and go on your way. It's a breast self-exam. It's a clinical breast exam. And it's mammography. That's what screening is right now. Again, all 3 of these under debate. Breast self-exam, there was a large study published out of China several years ago where they looked at 500,000 women. Now, these were Chinese factory workers, and they were taught on the job how to do breast self-exam, and they were followed for many years, and they used death from breast cancer as the endpoint. And they said that the group that did self-exam versus the group that did not, there were no differences later in death from breast cancer, so therefore breast self-exam must be worthless. Well, I've never heard of a study with greater bias. These were rural Chinese factory workers who were being taught and then asked by their boss, did you do self-exam? And they all said, yes. Right? I mean, it was a study with tremendous bias, but because the numbers were so large, many people took that to mean that breast self-exam must be worthless. But it also feeds into the fact that I think most people don't appreciate the goal of breast self-exam. It's not to tell the patient to come up with a diagnosis for every little lump and bump and thickened area. It's to tell the patient to be aware of what's normal for them and come in when something's new or different. No one can, no routine person on the street can do a breast self-exam and come in and say, yeah, this is fibrocystic change and this is this and this is that. And so there's a lot of confusion around the goal of the exam. The goal of the exam is to know yourself well enough to know when there's something new or different. And if you discuss it in that way with the patient, the light bulb goes off. They can usually figure out what you're trying to tell them to do and why it is helpful. And having done this for, 28 years, lots of patients find their own lumps. Lots and lots of patients. And so to tell them, well, all these Chinese factory workers didn't find theirs, so don't bother, isn't helpful. The other thing is that the risk of breast cancer for women living in Marin County by the time they're age 80 is 1 in 8. The lifetime risk for breast cancer among Asian women living in rural Asian communities, Japan, China, Vietnam, and so forth, is 2%. That's a 7-fold difference. Here, 14% risk, they're 2% risk. So they were taking a very, very low-risk group to begin with. I just don't think that it's fair to the women in California, in Northern California, to apply to them the results of a study done with a completely different population in a highly biased manner. Clinical breast exam. With time and with experience, you know when something's worrisome or not. You know what to look for, and you've got the tools to address any problems that come up. And finally, mammography. Mammography is 90% accurate. It's not perfect. Ballpark screening right now is starting at age 40 every 1 to 2 years, yearly starting at age 50, and then continuing until you think your patient is reaching the limit of their life expectancy. Has other significant comorbidities. What's being talked about, what's out there, what patients may talk to you about. First of all, there's thermography. Excuse me, if anyone is familiar with that, it's looking at changes in heat for more physiologically active tissue versus less so, with the idea that a tumor has a specific and enhanced blood supply and is going to light up or be hotter than other areas of the breast. It's not a terrible test, but its rate of accuracy is only about 75%. So since it's not as good as mammography, it's usually not covered by most health insurance. And when a patient does get a thermogram and pays for it, if it's abnormal, the first thing they do is say, go get a mammogram. So most thermography is not covered by routine health insurance, and we don't encourage or support it because the accuracy rate is lower. Breast MRI is being used more and more, and I think I already touched on the role of breast MRI in a patient who is gene positive. If you're BRCA1 or 2 positive, then it's an MRI yearly with a breast exam, with a mammogram every 6 months as well, and with a clinical breast exam every 6 months. So each of those tests is associated with a clinical breast exam. MRI tends to show everything, every cyst, every lipoma, every fibroadenoma. It leads to a high rate of referral for biopsy. It would be very poor as a routine screening test for everyone because it involves having an IV. It takes about an hour. And although open MRI can be done for, say, a knee or an ankle or a head or other soft tissue areas, there are no open MRIs with the breast coil for a breast exam. So the patient has to go through a very tiny tube. And for anyone who's never had an MRI, the tube is tiny. I mean, you get put on a table that moves. You're on like the Safeway conveyor belt, and it moves you down into a tiny tube, and it takes an hour. So patients can have a really hard time with it, and it's excruciatingly noisy. And even though the patients are given headphones or earplugs, it's like a jackhammer is next to your head and you're in the tiny tube and the exam takes an hour. So it is not appropriate for routine screening. But it is appropriate for certain subsets of patients. The other things about MRI is that they can be used once a patient has been diagnosed with a cancer. They can be very helpful in determining extent of the disease within the breast. You can use it to guide, is this patient a lumpectomy candidate? Does this patient need a mastectomy? It can be exquisitely sensitive for DCIS, which is those precancerous lesions or early cancers. And again, it can help you see, is it shooting down a duct and going too far? Or it can be a guide to your surgery. So there's a role for breast MRI. The role is increasing, but it is not ready for primetime routine screening because it has some significant negatives, some significant drawbacks. All digital mammography has pretty much happened unless you're in a really small town in a rural community at this point. Every major hospital and major radiology center has gone to all digital. There's some significant advantages in women with fibrocystic disease, in women who are still having regular periods. Digital mammography is better. It provides greater clarity. Heavily hormonal active breast tissue is very dense and you tend to get a whiteout. But as the breast tissue goes through the postmenopausal changes, it becomes clearer, it's easier to see through, and the quality of the study is better. But for women with dense breasts, for women with highly hormonal active tissue, digital is clearly better. And at this point, almost every major radiology center has replaced all their machines with digital mammography. The other advantage to digital is that with the computerized medical record, the patient's imaging can be transmitted literally all over the world. If there's questions, You can ask experts anywhere, look at these images, tell me what you think. And they can be, transmitted in a second or two. So it has huge advantages. Ductal lavage is still being researched. We still don't have an answer. It's a great idea, and I hope that maybe it'll be an approach to answering the question about DCIS. The idea behind ductal lavage is that you would cannulate the breast ducts through the nipple, inject a small amount of saline or other fluid, aspirate it back, and do a pap smear of the breast. And if there's early DCIS, maybe that's a way to follow it. Maybe it's a way to see changes. So far, it's been too painful and too difficult, and there are so many ducts that just going down one or two is not going to give you a complete answer. And so it is not yet something that's being done, but I think it's an interesting approach, and it could be something then, even if it remains painful or difficult, it could be a test that's done every 5 years, or that's only done to follow women who have had some DCIS changes, that you're trying to decide, is this patient going to be in the 50% group that gets an invasive cancer? I think there's potential there. It's still being looked at and researched. It's not something that's routinely done anywhere. When a breast cancer is diagnosed, these are the basic treatment options. And so as you're getting concerned, you're referring a patient, you're seeing someone back who's been diagnosed, just sort of like a ballpark of what are they facing and what's going on. We divide treatment into basically 3 zones. There's local treatment, which is treatment to the breast. There's systemic treatment, which is treating the whole patient in the event of concern about spread. And then there's complementary treatments. And I always use the word complementary, not alternative. I want the patients to see it as part of what's going on. Alternative, I think, sets up the idea that they're going to choose between traditional Western medicine or other approaches, and I think adding it in as complementary sort of sets the stage to say, do that too if it appeals to you, and you don't have to choose. So local treatment is surgery and often radiation. Surgery can be a lumpectomy, which is that you just go in and remove the tumor plus a thin margin of normal tissue to make sure that you got it all. And then mastectomy is, of course, when the entire breast is removed. Radiation is something that almost always goes hand in hand with a lumpectomy and is occasionally needed for patients even after a mastectomy. The other part of local treatment or surgery can be reconstruction. Reconstruction can be immediate, meaning on the day of surgery when the oncologic surgeon finishes, the plastic surgeon comes in, or it can be delayed, and some patients will opt for delayed. They'll get through all their treatment and then a year or two later go back for reconstructive surgery. Beyond surgery to the breast, the other part of local treatment is determining if the tumor has spread to any lymph nodes. And that result will factor into decisions about radiation and chemotherapy. Everywhere now, the approach to lymph node surgery is what's called sentinel node surgery. And very briefly, the goal is to find out if the breast cancer has spread to any lymph nodes under the arm. It's rare that it spreads anywhere else. It usually shoots directly to the lymphatic drainage. The anatomy is such that breast cancer would spread to under the arm in the axilla of the involved side. So on the day of surgery, you inject a bright turquoise blue dye into the breast area, and you also inject a small amount of a radioactive substance called technetium. It's in a vehicle that is selectively taken up by the lymphatics. Then during the surgery, you make a small incision up under the arm, and you look for the bright blue lymph node. You use a handheld counter. You look for the bright blue radioactive lymph node. You remove between usually 1 and 3. There's, in any given patient, there's anywhere from 15 to 30 lymph nodes under the arm. Those lymph nodes are also draining the hand, the lower arm, the upper arm, the back of the neck, the shoulder, sometimes even through the head as well as the chest wall. Your interest in a breast cancer patient is only to remove those lymph nodes that could be involved with the breast. This is a way of pinpointing the potentially involved nodes. The result is used to guide chemotherapy decisions. Excuse me. So then, systemic treatment. If you feel the cancer is spread, if it's involved in the lymph nodes, the patient is referred for chemotherapy as well as hormonal therapy. Early breast cancers, less aggressive breast cancers, are still responsive to estrogen and progesterone. The cells have not de-differentiated and gone so crazy that they're not responding to normal input. And so using anti-estrogen drugs can be highly effective in treating breast cancer. In really elderly patients with advanced disease, sometimes that's all we do. We don't even do surgery. We just give them an anti-hormonal drug, and they can peacefully coexist with their breast cancer for 3 to 5 years. So hormonal therapy plays an increasing role, particularly as the patients get older. Finally, complementary treatment includes massage, meditation, traditional Chinese medicine, spirituality. Massage, I think, is particularly helpful for patients when they're going through procedures in radiology, surgery, chemotherapy, and so forth. Having someone approach them and touch them in a way that makes them feel good is really helpful, because at some point they're so tired of being poked, hurt, cut, prodded, and everyone who approaches them is doing something to hurt them. It's really helpful to offer complementary treatment. And it's something to remember sometimes, even if the oncologist or the surgeon doesn't, as a primary care provider. You can encourage your patient to do something that's helpful and that feels good. I'm going to revisit the traditional risk factors here for just a minute. Again, the biggest risk is getting older, and it's age at menarche, first birth, and menopause. Nutrition, some of the things we know from more recent studies. Alcohol consumption is directly linked to breast cancer risk. There's a lot of data that came actually out of a woman named Margaret Wrench from USC, where she was an epidemiologist studying breast cancer. And as she got older, she had gone to school on a swim scholarship at USC. She was a member of the swim team. And when she started having reunions with the swim team members, she noticed that none of them had breast cancer. And so she started looking back at what they were doing. And it turned out that those women who had been highly competitive athletes consumed far less alcohol and exercised far more. And even into their later years, they were exercising far more. And there seemed to be a long-term protective effect. We know in research we've done on women in Marin County, which has one of the highest rates of breast cancer in the world, that a lot more alcohol is consumed. There was one study where they looked at 500 women in Marin recently diagnosed with breast cancer, and 86% of them had consumed daily alcohol, 2 drinks a week, sometimes 2 drinks a day, sometimes more, in the week immediately preceding the interview. And then they went to some small town in, Oklahoma or something, and asked 500 women how much alcohol they drank, and almost none of them even drank. There's no question that alcohol has a dose-response curve in relationship to breast cancer. So people who have 1 drink a day have less risk. People who have 2 drinks a day have more risk. People who have 3 drinks a day. And it just goes straight up. How much alcohol do you consume? How much is your risk for breast cancer? In general, the current recommendation from the Marin County Department of Public Health is that up to 4 servings a week is associated with decreasing your risk of heart attack, stroke, uncontrolled hypertension. There's that whole antioxidant thing from the grapes and so forth, and it's a good idea, in part because it implies that there's a social structure. Most people aren't sitting at home drinking alone. And so up to 4 servings a week seems to be neutral in terms of your long-term health, because while it's some risk for cancers, it's decreasing your risk of other things. But when you get into daily alcohol consumption, there's a clear association with an increased risk for breast cancer. One thing that we know that happens in patients taking birth control pills is that when they consume alcohol close to the same time, the levels of estrogen and progesterone temporarily spike 600-fold. So the thinking is that the alcohol consumption on a daily basis is causing daily spikes in estrogen and progesterone levels in a totally abnormal way, and that over a lifetime that's associated with an increased risk for breast cancer. There's also early data now looking at alcohol consumption in teenagers and patients in their 20s and later risk for breast cancer. One of the weird things about breast cancer is that the risk is higher in women of a higher socioeconomic status. And as one woman said at one meeting, she's like, well, why does my Harvard degree mean I'm going to get breast cancer? So we've tried to look through the Marin Women's study at what are the factors of a higher socioeconomic status that could be increasing risk for breast cancer. And one of them is definitely an increase in alcohol consumption, and it's an increase in alcohol consumption at younger ages. That people staying in the dorms at USC or staying in the dorms at Harvard and Stanford probably have more money and more access to alcohol than others. And so there's increasing data looking at the age of first drink, the age of regular drinking, associated that with use of birth control pills. And it's felt that there's just creating a bit of a toxic soup that is probably associated with an increased risk for breast cancer. So what you eat, nutrition definitely affects it. Again, obesity, probably anywhere from a 20 to 30 or even 40% increased risk. That fat cells are producing more estrogen through the aromatase enzyme, and obesity is a definite factor in breast cancer. It also limits treatment options. I mean, you have someone who comes in who's 400 pounds. They're hard to put to sleep, they're hard to operate on, their tissues don't heal well, and they don't do well with chemotherapy and IV access alone. And someone who is 400, 500 pounds, it is a nightmare. They have a lot of complications, a lot of problems, and they're at increased risk. Exercise, the more exercise, the less the risk. But it's pretty severe. It's not like heart attack or stroke where, brisk walking 30 minutes 5 times a week or whatever is helpful. The data on exercise increasing or decreasing risk for breast cancer involves vigorous aerobic activity, primarily during the premenopausal years, that results in a lifetime protective effect. And they're talking about 250 minutes a week of aerobic activity. That's when you start to see big changes. Maybe at 200 minutes, but mostly at 250 minutes a week. So that's a lot. That's a lot. That's like 50 minutes of running 5 days a week. And most people aren't out there doing 5 or 6 miles 5 days a week. So it's vigorous aerobic activity, but it is associated with a long-term decreased risk. One thought about that is that, of course, with vigorous aerobic activity, some people reach the point of anorexia, but many people simply have longer cycles. So if you're not exercising, maybe you have a 28 or 30-day cycle, and someone who's a big runner, competitive Nordic skier or whatever, maybe their cycles are 38 days or 36 days. But over the course of 2 or 3, 4 decades, they have accumulative fewer menstrual cycles, fewer of those peaks and valleys. So that's how the unifying theme of how we interpret that information. But certainly it's an area for discussion with your premenopausal patients. Is vigorous aerobic activity is helpful. Smoking. The data on smoking causing breast cancer is peppered. Some studies show it increases the risk, others do not. Most recently, it would appear that it's not the PAC years, so it's not, which is how we looked at lung cancer risk and how we look at cardiac risk, but it's the age at which the patient started smoking. So even if it's a half pack a day, if it's someone who started when they were 15 or 16, we know that nicotine is in breast milk within an hour of someone smoking a cigarette. So there's no question it's in the breast tissue. But it's not so much the cumulative pack years as it is the age at which the patient started. And some of that gets back to those pluripotential breast cells. That if before the first term pregnancy and nursing and the final division and maturation of the tissue, a patient has started smoking, that may be the key to the increased risk for breast cancer with cigarette smoking. And so some of the studies that have not shown an effect, or some of the debate in the literature over smoking and breast cancer stems from the fact that we were probably looking at the wrong thing, and that it's actually the age at which the person starts, not the cumulative pack years, that's affecting breast cancer risk. There's no question that it increases complications. That patients who are smokers, obviously their lung and cardiovascular status, they don't tolerate anesthesia well, they don't tolerate chemotherapy well, but their skin doesn't heal. And they're at much increased risk for infections in their incisions, for incisions that just don't come together, and then when you add radiation, their skin burns, it doesn't heal, it blisters, it scars. They have much greater risk for complications if they do get breast cancer. So again, remember, breast is a tissue that responds to hormones. And so one of the first things we look at when we're trying to decide treatment therapy for a patient, and the reason hormone levels are influencing your patients, breast tissue and breast cancers that retain both the estrogen receptor and the progesterone receptor. So we call them ER and PGR positive tumors. They are associated with a better prognosis because the tissue is not so dedifferentiated that it's lost its normal responsiveness, okay? But when they're negative for one or both receptors, that implies that the DNA is more disorganized, the cell's more disorganized, the cancer is more aggressive. Those patients don't do as well, and they don't have the option of responding to hormone treatment. They can't get the anti-estrogens and so forth. They're not going to make a difference because, in fact, their tumors are no longer responsive. So especially in an elderly patient, you've got an 82-year-old who's got, receptor negative cancer. One of your best options, which is the hormone therapy, is no longer available to them. And it implies that their tumor is more aggressive. One of the reasons that being ER/PR positive and being a candidate for the hormone therapy is good is that it has very few side effects. Remember, traditional chemotherapy is going to probably cause hair loss, weight loss, diarrhea, mouth sores, suppression of their white cells and platelets and so forth. Whereas hormone therapy is, for almost all patients, completely benign. It's a pill that they take twice a day with minimal to no side effects. And so it makes a huge difference to detect tumors early, hopefully before there's so much disorganization, because when your patient's still a candidate for hormone therapy, their life is much better and their treatment goes for them much better. The Marin Women's Study, which I'm a part of, is sort of part of what's going on now in breast cancer and breast cancer research, and it's something that's being done throughout Marin County. So for those of you who are here or who choose to practice here, what we're looking at is broad community participation in the study. 14,000 women have enrolled. We've got a broad panel of questions, and the results are linked to mammography results as well as DNA samples. So what happened is, in the mid-90s, it became apparent that throughout Northern California, there was more breast cancer than anywhere else in the rest of the state of California. And California has the highest risk of breast cancer in the United States. And the United States has the highest risk of breast cancer in the world. So the county health department brought in the CDC, and then the CDC brought in researchers from all over the United States, and they put together sort of a panel of questions, and they said, well, look at this, look at that, so on and so forth. Recalculate your data, and so on. So we did all that, and we still had an increased risk for breast cancer in Marin County. So they said, well, you know, you're like the canary in the mine shaft, and we don't know why, but there's no better place to look than here. So with funding again from the CDC, Center for Disease Control, actually with good support from Diane Feinstein, Barbara Boxer, Lynn Woolsey, they all, you know, the funding for the study was PORC, as it's otherwise known, but they got enough money put together that what the Marin Women's Study is, is for a period of 2.5 years, everywhere in Marin County, if a woman got a mammogram, she was asked to participate. And the study is 67 questions long. And we got input from all over in terms of even wild theories. What do you think is causing breast cancer? We asked people about the source of their drinking water, about their use of styrofoam cups and microwaves, but we also asked about hormone replacement, how many children did you have, how much do you weigh, how tall are you, how much alcohol do you consume, cigarette smoking history, recreational drug history, birth control use, family history. It was remarkable to us that 14,000 women did it. That is a huge participation. Something like 80-some% of all women in Marin ultimately agreed to participate in the study, which is such a credit to that community. But we linked it to their mammography results. So we can look at breast density, which is a risk factor for breast cancer, as well as whether or not a cancer was found. And the study is ongoing. So now, although the women have done the whole questionnaire only once, every mammogram gets fed back in. And then finally, patients were mailed and asked to spit into a special cup and mail that back to us. You chew a special gum, and then you spit into the cup, and we got DNA samples. And there's a repository of DNA samples in a basement at the Buck Research Institute now, and we've got something like 2,500 women linked to that. And now researchers from all over the world think that they've found a gene or a sequence or an issue that might be linked to breast cancer, or can you look at vitamin D levels, can you look at this enzyme level, or whatever. And so part of our role now is to be stewards of this situation. Since we started the study, some of the patients who did not have breast cancer and subsequent mammograms developed breast cancer. So then we have that group of people. We have the people without it, the people who developed it, the people who had it, and DNA samples, mammography data, as well as a broad sense of risk factors for all these patients, all these people. And so it's part of where the early smoking data came from that I talked about already. It's certainly confirming the alcohol consumption issue. I think it's going to be very interesting to see with the assisted reproduction where that goes, because that's very popular in Marin to have kids in your late 40s and early 50s, even mid-50s. And so I think looking at their ongoing risks for problems is going to be very important. And the most recent finding we had, and we have no explanation thus far, is that women who developed pregnancy-induced hypertension have a long-term decreased risk for breast cancer. We've got a couple of grants out there. We're researching it more. We don't know whether it's a change in the character of blood vessels or a change in responsiveness to the hormones of pregnancy or whatever, but remember, that's that pluripotential cell differentiation time. So is there something about the hypertension and the final differentiation of the breast tissue? Because usually pregnancy-induced hypertension is a late pregnancy situation, last trimester, and sometimes induced labor at the last minute because it's getting out of control. But there seems to be a decreased risk for breast cancer in patients who are developing pregnancy-induced hypertension. And that's one of the results of the study that we're following up on. That I feel really blessed to be in a community where so many people are connected to what's going on and willing to participate. And we're one of the first studies that developed a DNA bank. It's becoming increasingly a research thing, and it's a very long view. I mean, it could be 10 years before we can come up with more hard and fast recommendations, but the idea was to start. This is sort of breaking down breast cancer just over a 2-year period in Marin and looking at the rest of the state of California. One of the CDC recommendations was, well, do you have a certain type? Are you getting only the receptor negative? Are you getting this? How are you different from other parts of the state? And what we found is we're really not. We had no one particular group that stood out. So if you're trying to say, well, you know, it's PCBs in the water, and PCBs in the water are linked with a certain type of an increased risk for breast cancer, or there were a lot of theories. So one of their recommendations to us was to look at the breakdown of the types of cases in Marin versus elsewhere and see if anything stood out. And what we found was that it did not. The other things we've done is we mapped breast cancer by zip code, and we looked at population density, superimposed those two, and there was no particular area. It wasn't that, you know, if you lived near Hamilton where there may be toxic flumes under the ground, or if you had a certain water supply, or, you know, was there a neighborhood hotspot. The community had a lot of questions. And part of the Marin Women study was to have town hall meetings. We had a lot of town hall meetings in the Board of Supervisors chambers, and we tried to address the questions that the community was asking. And one of them was, you know, are there hotspots? So we did the zip code map. We did the analysis looking at types of cases to try to address concerns in the community. When you look at incidence by county in California using the 2000 census data, unfortunately we only get census data every 10 years, and so that changes our denominator constantly. But when you look at the 2000 data, in general, Northern California is up there compared to other counties. And then the rate per 100,000 population, the age-adjusted rate per 100,000 population nationally is 120. So you put that 120 up against those other numbers for California, and it's still pretty significant. There's still a problem here. And so there's still a lot of reason to be concerned. And I think in terms of screening, I think women in California and in Northern California should be considered for a different screening approach. And if you live in a low-risk community in Idaho, maybe every 2 to 3 years in your 40s and so forth is very reasonable for you. But we don't know what's going on here. And I think applying the same screening approach to women throughout the country, when we know that this is an area of higher risk, of undetermined cause, is probably not appropriate. Now, that's my personal approach to it, but I think when you're talking to a patient, that usually makes sense. That it's not fair to them to screen them as if they had the same risk of a woman who lived in another area. The good news is that most people in Marin are insured, and so the death rate from breast cancer is declining over the last 20 years and is slightly less than the rest of the state. But that led to a lot of people asking the question, well, is it that everyone in Marin is insured so they all get mammograms? Actually, because there are a lot of people with different approaches or who have busy lives, the rate of mammography among women in Marin is average, middle of the pack. It's not particularly higher or lower. So the rate of breast cancer is greater, but the number who are getting mammograms is average. And so it's not that they're getting screened and that we're picking things up. The good news, though, is that they do have insurance, they do get good care, and that the death rate is continuing to decline and is less than the average for the rest of the state. This is just sort of a nice, colorful picture, but it gives you that idea. The areas marked in red are those with the highest rates for breast cancer, and the bright blue is the lowest risk. Nationally, there is some sense that living on the water increases risk. So the other hotbeds across the country are Long Island and Cape Cod. And as you look at this map, although there's some inland areas in general, it's the coastal communities, the coastal counties, that have the highest risk. Although, as you go to the north, there's the lowest risk in those people who, you know, are living on the coast. So it's not clear exactly what it is, but that gives you sort of a nice picture of the risk. And again, as you look at those numbers, remember that nationally it's 120 cases on average per 100,000 population, and here it's closer to anywhere from 140 to 160. In the 90s it was as high as 180. When the nurses study, and there was a teacher study, when those results were published in 2004, most women went off hormone replacement therapy. Most women who were taking postmenopausal hormones, it became clear that it actually slightly increased your risk for heart disease, increased your risk for stroke, increased your risk for breast cancer, was not doing any of the things we thought it was going to. And so within 2 to 3 years of women in Marin stopping hormone replacement therapy, breast cancer rates fell by 33%. And that was a dip that has slightly started to go back up again. But the thinking is that people who might have been predisposed or at increased risk had their tumors incited by the hormone therapy. But one of the conclusions we came to from this was that if nothing else, Marin and women listened to the media. It was all over the news, it was in the newspaper. And most women said on the Marin Women's Study that no, they didn't go to their doctor and ask, they just stopped taking the hormones. They read about it, they saw it in the paper, and they stopped taking the hormones. So that's the good news, is that people listened to the media, they were paying attention to what was going on out there. The bad news is that now the confusion generated over screening, people are also listening to that. And so it's increasingly becoming a discussion. And it's a discussion you want to well document, because you don't want to forget 40% of cases of malpractice cases are due to missed breast cancer diagnoses. So if you offer mammogram and the patient declines, you want to have a pat phrase that you're going to put in your clinic note saying, offered mammogram, discussed risk benefits, current controversies, patient decline. But you don't want to not offer and your patient's 52 and never had one, and they just say no thank you, and nothing further happens. A couple of other things that are being looked at right now. One is a large project called the Bay Area Breast Cancer and the Environment Research Center. Nationally, 5 centers were identified to look at the environment and its potential interaction and its contribution to increasing risk for breast cancer. So of course, putting it in the Bay Area made perfect sense, and we were able to succeed in getting that accomplished here. The basic idea is that puberty represents a window of susceptibility, that the pluripotential cells rapidly divide between the ages of 9 and 15 for most young women. And so they're looking specifically at toxic exposures and about what's happening in young girls. And one of the ways they're doing that is using Kaiser. In Northern California, Kaiser Permanente in any given community insures 40 to 60% of the population. And they have the opportunity to look at both the mother and the child. And so they're using the Kaiser database for a big part of their research. What they've found is that in utero exposure to PCBs and DDTs, the young girls show signs of puberty earlier, and that is a breast cancer risk factor. The earlier the age of menarche, particularly in children who are having their first period at age 9 and 10, clear association with an increased risk for breast cancer, again getting back to the idea of more and more hormonal spikes over the course of the lifetime. And again, girls with earlier puberty were found to have higher levels of phthalates. Interestingly, higher lead levels delayed puberty. So they tested for other toxins, but these were the 3 that showed significance: the PCBs, DDT, and phthalates. So what are these drugs? Well, they're basically thought of as being estrogen-like. So the PCB is in contaminated fish, high-fat foods, and water, depending on where your water supply is. And then DDT was actually outlawed in 1972, but it sticks around forever. And so both of those are acting like estrogen-like compounds. The phthalates are found in plastics, personal care products, and fragrances. And our FDA kind of bails on cosmetics. And in Europe, phthalates are pretty much eliminated in most personal care products, lipsticks, lip glosses, and, you know, skin things and so forth, but not here. And so you can still have a lot of chemicals and problems in cosmetics here that you don't get in other countries, and they're not tested. So it's a huge unknown. But it's felt that it's a reason for rising rates, that in the 40s and 50s, 11-year-olds weren't using lip gloss and fragrances and lotions and potions and so forth the way they are now, and that all these things are just sort of part of an increase in the overall level of toxic soup that people are exposed to that's associated with the rising rates for breast cancer. The other thing very interesting to me, I was at a environment in the breast cancer meeting about a year ago, and there were extraordinarily high levels of phthalates in PCBs in receipts. So when you go to the ATM and in the thing your receipt shoots out, there's something about the paper and the ink and the heat process for how they generate those things that had incredibly high levels of those chemicals in them. And it just shows you how ubiquitous it is and how difficult it is to pin down a single cause for the increasing rates for breast cancer. I mean, I don't think we're going to succeed because it's so subtle, but at this point, it's everywhere. And I thought that that was an odd and very, very interesting finding, that one of the things that's just sort of out there in your daily life with some of the highest levels of these substances was these heat-generated receipts that shoot out of everywhere. The Trader Joe's machine, the ATM, everywhere you go, that stuff. And it gets right on your fingers. It gets right on your fingers. Final study I wanted to talk about just briefly is again called the SIGNET study, the cohort study of young girls' nutrition, environment, and transitions. They're looking again at is puberty starting earlier and are environmental exposures responsible. They started with girls at age 8. This is mostly the work of Larry Cushy, again a Kaiser Oakland breast cancer researcher. And they are doing both blood tests as well as extensive interviews with girls age 8 and their mothers, and then following them to age 16. And then following long-term with a commitment that should anyone develop a cancer or a significant problem that they would feed back to the study. And it's one of those things where it's just going to take 30 years. But they started, they're doing it, and already they are finding as well that puberty is starting earlier for sure. It's starting earlier in young women who are overweight, and it's definitely confirming the results of the other study that certain exposures are linked with higher rates for early puberty. And we know that early puberty is associated with higher risk for breast cancers. And I think that's it. Any questions about any of the stuff that we've covered? Yeah.
For the women that engaged in the brain survey for breast cancer, were the women local, homegrown to Marin, or were they transplants from different areas of the country?
That's a great question. So for anyone who might not have heard, the question is, the participants in the Marin Women's Study, were they women born and raised in Marin, or were they people who moved there? We looked very carefully at that before we even started the study, and it was one of the recommendations to us from the CDC when they first came out, is to look at length of time of residence in Marin, and it had no effect whatsoever. Yeah.
Were there any women engaged in the study that had transplanted from, say, Long Island or Cape Cod, where there is also a higher incidence?
The women who moved to Marin come from literally all over the country. And there's no association between length of residence in Marin and an increased risk for breast cancer. So some of the patients who develop breast cancer who live in Marin moved there a year ago from Eureka, and some of them moved there 20 years ago from New York. and there doesn't seem to be any relationship between length of time, length of residence, which causes us to think that it's not a local toxic exposure. Because otherwise, clearly, our cases would be among people who live there longer. But it causes us to think it's more lifestyle factors. And the way I sort of put it together is that as your socioeconomic status increases, you can afford to move to Marin. But having lived there a long time and raised my children in Marin, the women of a higher socioeconomic level really get exposed to a toxic soup that affects your liver metabolism in a way that other people don't. So people living in Marin are more likely to have all those ATM receipts and whatever. They're more likely to consume alcohol. They're more likely to get their houses sprayed for bugs. They've got new carpet and the smells associated with that, new paint, remodeling. What the heck is going on when all that happens? I don't know what the new car smell is, but I think it's bad. I think you're offloading phthalates and all kind of PCBs and so forth from refinished wood and carpet and upholstery, and I think there's just a generalized toxic soup exposure that goes with a higher socioeconomic status. But I think that's why length of time living in Marin isn't the issue. Because if it was, it would be likely a single toxic exposure within the community, in the soil or the air or the water. And that's not what we're finding.
Last question. What is the socioeconomic status of Marin females compared to similar socioeconomic statuses of, say, Marblehead, Massachusetts, which is similar to Marin County?
In general, Marin County has one of the higher socioeconomic status in the United States. That some people think that that's what's going on in, say, Cape Cod and Long Island, is that you need a certain amount of wealth to live there. But the thing that makes Marin County different is that, like, Marblehead is just a community, right? It's a town. But in Marin, it's a whole county. And because cancer rates are reported by county, we're not offset or offloaded by the poor areas of the county. Almost the whole county uniformly is insured and is living in an area where homes cost a lot, and you need a higher socioeconomic status to live there. Even when you look at, say, Beverly Hills, well, the problem is Beverly Hills has East LA in the same county. And so when you look at county-wide statistics, you don't, they're watered down by other communities. And so we're one of the few counties where the whole county is quite homogeneous. And so that just helps with figuring it out and using census data. Oh, you're welcome.